We hear a lot about medical surgical errors like operating on the wrong limb or the wrong organ or the wrong patient. But I want to talk to you today about a hidden risk of surgery. And here's what that risk is. It is possible for you or I to go in for a surgical procedure or a colonoscopy or other invasive medical procedure and come out infected with HIV or hepatitis C. This risk is never disclosed on the surgical consent form that patients must sign before surgery. The good news for patients and the general public is that there are questions that you can and must ask your prospective surgeon before you schedule any surgery. And these questions can help protect you from this hidden risk, as well as other commonly known surgical mistakes. By the time I'm done, you will know what questions you need to ask. I will also, at the end of the talk, present an idea for a new type of surgical consent form that was developed here at HealthWatch USA. The currently used informed consents protect the surgeon and the facility from lawsuits. That's the intent. But that form does nothing to protect excuse me. That form does nothing to protect the patient from preventable harm. The new form that we're proposing will protect patients from harm while still protecting the surgeon and the facility from liability. So we're talking about potentially being infected with HIV and hepatitis C and other pathogens, potentially deadly infections. But this is preventable, and I will show you how it is preventable. There is technology available to surgeons and other OR personnel to reduce this risk. It's been around for decades. The nurses in the OR and the scrub techs take this very seriously and are totally on board with it. But it's the surgeon that decides what instruments will be used, and surgeons are not on board. So my fellow surgeons have failed to correct this problem from within the system. So I believe it's up to informed patients to apply consumer pressure to change what our system has failed to do. Why did I write a book about this? Because I felt very strongly. I was frightened on numerous occasions by needle sticks, scalpel cuts that I had endured, despite being careful. And I was lucky I was not infected, but I've met surgeons, nurses, and scrub techs who have been infected, and it has affected their careers and their lives, obviously. HIV and hepatitis C are commonly found in the blood of surgical patients. And many of these patients don't know they're infected, and they're not all tested. But even if they were all tested and surgeons didn't do anything to protect against exposure, what would be the point of testing? The fact is that U.S. surgeons and assistants are injured with needles, scalpels, and other sharp objects an astonishing 1,000 times a day. This exposes them to the blood of potentially infected patients. As a result of these exposures, surgeons may become infected with HIV and/or hepatitis C. And here's the danger to their future patients. The surgeon may not realize for months or even years that they're infected. So infected surgeons can then transmit these diseases to future healthy patients during their procedures. HIV and hepatitis C can also be transmitted to healthy patients by contaminated, improperly cleaned instruments and devices, such as colonoscopes and dialysis equipment. The CDC found 385,000 needle sticks and other injuries with sharp surgical instruments occurred in 1 year, or about 1,000 a day. Whether or not someone becomes infected as a result of a sharp injury and exposure to infected blood, for the injured party, whether it be the healthcare worker, nurse, tech, surgeon, there's going to be anxiety, stress, shock, pain, and suffering after each one of these exposures. And the blood testing that then becomes necessary can take up to 6 months to find out if you've been infected with HIV. In terms of wasted healthcare dollars, these preventable sharp object injuries cost the healthcare system more than $1 billion annually for lab tests, medications, counseling, and staff replacement. You may be sitting there asking yourself, how does this apply to me or my family member or my good friend, and why should I even worry about it? Well, here's why. According to a recent study by the American College of Surgeons, the average American will have over 9 surgical procedures in a lifetime. So it's not a question of if, but when. So now you know that that exposures to these potentially deadly infections are common. You can prepare yourself with information that I'm going to provide, and you can become an empowered safety advocate for yourself or a loved one. As a consumer of healthcare, you have the power to protect yourself, and you must use that power. Just how much of a risk is exposure to these infections? In one urban surgical practice in Baltimore, researchers found HIV, hepatitis C, and hepatitis B in 38% of patients undergoing surgery, including HIV in 26%, hepatitis C in 35%, a combination of HIV and hepatitis C in 17%. Making matters worse, surgeons in particular among healthcare workers usually fail to report their injuries. This deprives them of the opportunity to receive post-exposure prophylaxis, which could prevent HIV, and the opportunity to diagnose hepatitis C early when it's more easily curable. After a surgeon becomes infected and subsequently is injured again, and his bleeding hand recontacts that healthy patient's internal tissues, that patient may become infected as well. That is the mechanism. Now, this risk does not appear on surgical consent forms and is not discussed preoperatively with patients. How and when did we first learn about this risk to patients? Here are some of the earliest known cases. Between 1987 and 1989, the CDC found that a Florida dentist who was infected with AIDS transmitted HIV to 5 of his patients. In 1999, a French orthopedic surgeon infected with AIDS transmitted HIV to a patient during a hip replacement. In 2003, an obstetrician in Spain infected with AIDS transmitted HIV to a patient during a C-section. And between 1991 and 2005, worldwide, 11 surgeons infected with hepatitis C transmitted those infections to 38 patients, including 14 in the U.S., and 12 surgeons infected with hepatitis B transmitted their infections to 91 patients, including 19 in the U.S. What we don't know is this the tip of the iceberg? Let's look what happened in the following decade. Between 2005 and 2015, in multiple reported exposure incidents, hundreds to thousands of patients were or may have been exposed to HIV and or hepatitis C during colonoscopy, dialysis, and major surgical procedures due to improper cleaning and sterilization of equipment and due to sharp injuries to surgeons. I like to call these exposures never events because almost all of them are preventable. The fact is, that most sharps injuries and exposures to blood are preventable by using safety devices, which I will describe in a minute. And in fact, a federal law, the Needle Stick Safety and Prevention Act, passed by Congress in 2000, requires that surgical and medical facilities must provide for employees the following: safety-designed injection needles, blood draw needles, IV catheters, safety scalpels, and blunt-tip suture needles. Here's the problem. Surgeons may choose not to use these if, in their opinion, part of the law, they interfere with patient care. Well, the truth is, they rarely interfere with patient care. I have a lot of experience with them. Yet only 5 to 10% of surgeons use these devices. Let's look first at blunt tip suture needles. They easily penetrate tissue layers below the skin, but not the skin. So everybody is protected. Everyone on the surgical team is protected from a suture needle stick. In a classic CDC study, there was a 0% needle stick injury rate to healthcare workers with these blunt needles, compared to a 6% rate when traditional sharp suture needles were used. Quoting now from the American College of Surgeons 2005 Bulletin Statement on Blunt Suture Needles, quote, "All published studies to date," and there have been many, "have demonstrated that the use of blunt suture needles can substantially reduce or eliminate needle stick injuries from surgical needles. The American College of Surgeons supports the universal adoption of blunt suture needles as the first choice for closing incisions, that is, fascia and muscle." And similar endorsements have been made by the American Academy of Orthopedic Surgeons, AORN, the perioperative nurses, the Association of Surgical Technologists, Surgical Physician Assistants, OSHA, and the FDA. And yet, in spite of this, surgeon compliance is about 5%. What I'm demonstrating in this photo is that I'm trying to stick my finger with this blunt suture needle, and it's just about impossible. The next thing I'd like to talk about is the fact that surgeons would do well to pass sharp instruments using a neutral zone. That's what that looks like. This one example could be a mat or any kind of a tray. I like this one. And use this neutral zone instead of passing them hand to hand between workers. This is where collisions often occur. And the fact is that half of all scalpel injuries, the second most common type of injury, and a quarter of all suture needle injuries, the most common injury, occur when these sharps are passed from hand to hand. So using a neutral zone has been shown in one study to significantly reduce sharp object injuries due to collisions. Unfortunately, surgeon compliance with this is sporadic. The way this works is the surgeon asks for a sharp instrument, let's say a scalpel. The nurse places it in the tray. The surgeon takes it, uses it, replaces it there, and the nurse takes it away. The next thing I'd like to mention is double gloving. And this is something that surgeons should do, but often don't. Wearing 2 pair of gloves reduces the risk of exposure to patient's blood in multiple studies by as much as 87%. And the American College of Surgeons also recommends the universal adoption of double gloving. Surgeon compliance is variable from hospital to hospital. The fourth thing I'd like to mention that surgeons should use but often don't is safety scalpels. There are a few studies on this, But I can tell you from my experience over more than 10 years in the OR, using safety scalpels, that they're easy to use and they're a good way to prevent injuries and exposures. They do not interfere with patient care in most situations, but surgeons are resistant to change. They say these don't feel the same as the traditional, less safe standard scalpels, but they work well, and compliance is probably less than 5%. This is an example of one such safety scalpel. There's a sheath that covers the blade. When the surgeon uses it, the sheath is pulled back and then replaced. These can be reusable, disposable. This particular one, is a module that clips onto a standard scalpel handle. So that should make surgeons happy. It feels the same. Well, they're not happy. So, non-compliant surgeons are missing opportunities every day to protect the patient and the surgical team from exposure. Safety scalpels and blunt suture needles have been available for 2 decades. They can prevent a majority of the 1,000 injuries that occur daily. Why don't surgeons use them more often? Well, it's resistant to change and there's no pressure. As far as OSHA, inspections are infrequent. OSHA is underfunded and understaffed, like most agencies. And when a violation is found, there are not always strict penalties applied, although sometimes they are. So the only solution left, in my mind, is consumer pressure. So here's what patients need to do. You need to find the transparency, which is what we're doing today. Learn about the risks and apply that pressure. Speak up and ask questions. Challenge care providers to follow safe practices. Patients need to demand safe care. We are all going to be patients, and we deserve it. In addition to washing your hands, this is something you could say to a prospective surgeon. In addition to washing your hands, which I know you're going to do, and as you know from previous speakers, if someone's watching or surgeons are requested to wash their hands, they're more likely to do so. But I'd like you to also to use the following safety devices during my surgery, the ones that I just mentioned. So you have to be your own safety advocate, and always bring someone with you as an advocate for backup. Don't go into a doctor's office, hospital, surgery center, or clinic without someone to help protect you, because you're not going to hear what the doctor has to tell you. And you have to use safety checklists of your own, because surgeons don't use them like they should. I've got 6 checklists in my book. This is the first one, and possibly the most important in my mind. What you must ask a surgeon the first time you meet, once you're scheduled for surgery, is too late for change. So you ask, do you use blunt tip suture needles to close your incisions? Do you use a neutral zone for passing your sharps? Do you double glove? Do you and your OR team all use protective eyewear? Do you use safety scalpels? As I say, once you're scheduled or in the OR, it's too late to have a conversation. So the goal is to get the surgeon to agree to use these things, except where they could interfere with care, and that's a legitimate concern. But I can tell you they don't interfere. They mostly help. So what have we learned today? A hidden risk of surgery has been revealed, and that risk is exposure to HIV and hepatitis C in surgery. It's mostly preventable with available safety devices, but many surgeons don't use them. Some do. The healthcare system has failed to change surgeons' dangerous behavior, and the only remaining solution is informed and empowered patients who will apply consumer pressure. Patients, meaning the public, and remember, all of us will be patients, need to know what questions to ask so everyone will be protected as much as possible. So I plead with you to ask these questions, speak up to protect yourself, your family, and protect your surgeon. They may not know they need that protection, but they do. I believe surgeons want to do the right thing, and I think they will if you just ask for it. They may even thank you. And now I'd like to mention that new consent form. And this is something that's been developed by a coalition of surgeons and safety advocates here at HealthWatch USA. The so-called Preoperative Patient and Surgeon Mutual Protection Agreement. This is in addition to the standard consent form. This protects patients from preventable harm. It can avoid exposure to bloodborne pathogens, improve occupational safety for the care providers, protect those care providers from professional liability. And if you go to the HealthWatch USA website, you can find a prototype for this agreement, and I'll show you more about it in a second. You can find it there, look at it, download a copy, show it around, edit it to fit your facility's needs, and give it a try. And let us know how you like it. So basically, among other things, this form, the surgeon will attest that he is board certified and credentialed to do the procedure. So that way you know that that's the case. And that the surgeon will personally perform the surgery. This doesn't always happen. If they're unable to perform the surgery for some reason, they will get permission from the patient. The surgeon agrees to be present for the timeout and the site marking. All alternatives to surgery have been discussed, including the wait-and-see approach. If a medical device is to be implanted, the name, brand, serial number, and manufacturer should be provided. And the surgeon should divulge non-hospital employees who are going to be present. Now, if a Sharps injury should occur where there's recontact, that is where the surgeon's injured, the surgeon's finger's bleeding, that blood goes into the patient's incision. If that should occur, both the patient and the injured care provider should be tested for HIV, hepatitis C and B, and other pathogens where appropriate. What's good for the goose is good for the gander. You're asked to give your permission to have your blood tested when you undergo surgery. But if an injured surgeon bleeds into me, I would like him to be tested too, so I don't have to wonder. Of course, the results will be given to the patient and the care provider, and these results will remain strictly privileged and confidential. Thank you very much.